Whether you're in EMT school or paramedic school, you're going to see this term a lot. Acute coronary syndrome. What that is, your coronary artery is under attack, whether it's a blockage or a spasm of your coronary artery. Your coronary artery feeds the heart muscle. That's a heart attack. That's what we're going to talk about today. Now, what we're going to talk about today inside of heart attacks is EKGs and placements. You're going to want to stay to the end. I got a ton of tips for you. Wherever you are, from EMT to paramedic, let's dive into it. So the first thing we're going to go over here is our leads. Now, I have a life pack here I just want to show you. First here we have, these are our limb electrodes. We have a white, black, red, and green. These are the limb leads. Because we place the leads or the electrodes, more on that later, on the limbs. Then we have the chest leads. Now the chest leads here, okay, V1 through V6 are placed on the left side of the chest. I'm going to show you first how to place electrodes when we're doing an EKG. Now first, why do we do this? And what do we uncover when we actually do this? These limb leads, okay, which I'll give you a mnemonic for in a moment, that is going to give us, we're going to actually determine what the rhythm is of the EKG. So that is rhythm recognition. Now, when we put these chest leads on the patient, we're now getting the full EKG. What do we get with a full EKG, a 12-lead EKG? Well, I want to plant a seed in your head. Let me do it now. When I say the term leads, I mean views of the heart. A 12-lead EKG gives you an inside look based on the electrical conduction and the waves that you're going to see on the EKG, what's going on inside the heart. Our limb leads are going to give us the underlying rhythm. The 12-lead EKG, views of all the sections of the heart. So we can see if one of them is under attack and they're having an acute coronary syndrome. Okay? Now, with our limb leads, I have a diagram over here. Here's some mnemonics for you. So you always want to start with the right arm. Now, the white electrode goes on the right arm. We could put it here on the inside of the wrist. We can put it up here on the humeral head. Whatever works for you. Okay? Now, white, when I think about the white electrode, I want to give you a mnemonic. Snow falls on top of the grass. If there's a fire on the ground, smoke rises. Snow, it is above the ground, grass. Smoke, it's black, over fire, which is red. Green is the ground. What that means, right arm is white. That's the white electrode. Green is the ground, green is grass. That's the right leg. And funny enough, that's our ground electrode. It's cool too. Black is our left arm, and red is our left leg. So again, here they are, right here in front of us. We can see this electrode would go here. Right arm, right? The black, right here. Legs are out of shot, I know that. So again, right and left leg, green and red. We can see it visualized over here. Now let's go to the next section here. So here we have a visual representation of our chest leads. Now let's say you're a brand new EMT. I want to show you real quick. You got a paramedic you're working with for the first time, and they say, can you put the leads on for me and do a 12-lead? Here's what you got to do. This little box, I'll show you. See this box right here? Right here, these are my 12-lead cables. I got to stick this box together. So now we get this. And then the other end of the cord, which you can't see, it's off camera, is going into the life pack over there. And then we hit 12-lead on the monitor. And may I ask you prompts about what is the sex of the patient, what is the age of the patient, depending on the monitor. And then you go through, enter, and then it is a 12-lead EKG, tell them to hold still. Now, that being said, where do we put these chest leads? I'm going to show you. So these chest leads, first we have V1. You want to go in order here, but as a caveat, I'm going to show you. So V1, we put on the right. So first we got to find the sternum, right? Easiest way to find the sternum. You can roll down into your trachea down here. You're going to feel like a little raised section, if you will. You're going to scan over. Now we're in the intercostal spaces. Move on down till you're at the right sternal border. Sternum right in the middle of your chest. You really can't miss it. And it's going to be the fourth intercostal space. That is where you put V1. Right across from V1 is V2. Now you would think, well, what does go to V3? Well, hold on a second. Look at V3's definition. V3's definition is midway between V2 and V4. So if I haven't placed V4 yet, why would I place V3? That's what I'm getting at. So after you do 1 and 2, move to 4. We have to go to the left side of the chest, and it's a fifth, so go down one more intercostal space. To the fifth intercostal space. Mid-clavicular line. What's that mean? Well, my clavicle's up here, right in the middle of it, okay? Use the clavicle. That's going to be your guide. Mid-clavicular line, fifth intercostal space. Place V4. That's going to set you up for V6 and V5. Now, a lot of people like to get V6. I like to say it's essentially the line underneath your armpit in your t-shirt. That's your mid-axillary line. In the fifth intercostal space, that's V6. So I like to go 1, 2, 4, 6. Because then pretty much the anterior axillary line is kind of, if you have your say your lat, for example, the front part of your chest, you shoot down anteriorly, okay, so right on the side of your chest going down, that's going to be your anterior axillary line. Okay, it's in front. It's not underneath your armpit. It's more in front, right? But that's literally, if you look, right in between 4 and 6. Okay, then that's rolling over. It's not an exact diagram. It's giving you a point. Now, V3, simply, we've already placed everything else. Now we go back and place V3. So I like to do 1, 2, 4, 6, 5, just plug it in, and then 3, plug it in. Now we have good placement. Folks, big tip, you can't get too good at this. So when you're doing your lab time, you're doing your clinicals, practice placement of EKGs with each other, find the intercostal spaces. Don't forget too, when you're doing stuff like needle decompression, you gotta find intercostal spaces, get good at that. And for people that are not particularly thin, or people that have a lot of muscle on their chest, or a lot of fat in their chest, it can be hard to get down deep there. It's something that are really deep to find the intercostal spaces. That's a quick pearl and a quick tip. What we're looking at right here is a normal sinus EKG across the board. Rhythm and 12 lead. There's no heart attack here. I'm showing you this to show you what normal is, because later on I'm going to show you what's abnormal. And I'm going to show you a heart attack as we go through this. Actually, I'm going to show you two different ones. Now, what's the first thing we do when we get a 12-lead EKG? First, we look at lead 2. Here's lead 2, lead 2. Now, not every monitor is going to give you lead 2 all the way across the bottom like this. Usually in hospital, they have those. But I'm just showing you for reference. Let's just say here on lead 2, here's your rhythm strip. And then everything above that, that's a 12-lead EKG it prints off on your monitor in EMS. First thing we do before we get into 12-lead, you got to tell me, what is the underlying rhythm? Well, the underlying rhythm here, we can see the rate is normal. I have a P for every QRS. P waves and T waves are upright in lead 2. The QRS is narrow. Again, the rate is normal. It's regular. It's normal sinus rhythm. What I do when I look at a 12-lead EKG, I have a lot to share with you here to unpack, so please hang with me, get your popcorn out for this. Now, when we look at the EKG, see these little boxes, 1, 2, 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. These are what I was talking about earlier when I meant leads are views of the heart. If I say, what is lead 1 looking at? Well, I can tell you it's looking at the lateral wall of the heart. What is lead 2 looking at? looking at the inferior wall of the heart. Hey, what is lead V1 looking at? The septal wall of the heart, to name a few. We're going to go through all this. But I just want to point out something very important. These are all different views of the heart. And we're getting just a quick, what an EKG, remember, it's just a quick picture. Boom. Quick picture of the heart at that time. Folks, another pearl for you. You have a patient, chest pain, difficulty breathing, shortness of breath, nausea, vomiting. Oh, I'm so weak, I can't get out of bed. Hey, there's something wrong with her. She's not herself. You should be doing minimum 2 to 3 EKGs on that patient during your care. Even if you work, and I've worked, even if you work in city EMS, where, it's a short transport time, you can't get it. You should be getting at least 3 EKGs. Let's say you got one on scene, you get one en route, and then get one right before you transfer care. Very simple. Do one while you're waiting in triage. Remember, an EKG is only a picture in that moment. And heart attacks develop and change over time. So one of my big pros to my students is, when in doubt, you got a funky EKG, keep burning EKGs. Okay, now, with that being said, I got to share something with you about the leads. Let's go to our next slide. Now, before we go any further here, I need to show you what elevation looks like, what depression looks like, and a few other characters I got on my board here. Essentially, we're going to learn here what the waves are and how different waves can look and what they might mean. But look here. Here's our normal EKG. P wave is the first positive deflection, meaning the wave points up on EKG. It's a P wave. The Q wave is the first negative, meaning it points down, negative deflection on EKG. The R wave is the second positive deflection on EKG. The S wave is going to be our second negative, meaning it points down, negative deflection on EKG. And the T wave is the third positive deflection on EKG. The isoelectric line, just remember this, it's so simple. See this flat line right here, right in front of that P wave? That is the isoelectric line. Remember that? I'm going to share with you why in a moment. Now hang with me. The P wave represents what? It's the atria firing. It's the electrical impulse going through the heart. It's the atria's turn to fire. It's in atria, you're up. The ventricles is a QRS complex. That's when the ventricles fire, depolarize. That's when the electrical impulse is going through the ventricles. The T wave represents the ventricles relaxing. They're relaxing, okay? We don't see when the atria relaxes because the giant QRS is in the way and the ventricles are stronger than the atria. There's a very important point I need to tell you about here. See right at the end where you can see the end of that S wave and it goes to a straight line, and then right at the beginning of that T wave, that straight line between the S and the T is called the ST segment. So what was that? The ST segment can only be okay, good, elevated, or depressed. 2 out of 3 of those are bad. 1 is good. Stay tuned. When we get into other videos, there are many reasons why you would have ST depression or elevation, and not all of them are heart attacks. But what I'm going to show you in this video right now is what a heart attack looks like precisely and consistently on EKG. So you know it. You won't miss it. There's a certain pattern I'm going to show you. It starts with the presence of ST elevation. And we're going to talk about where that is in a little bit. So here's ST elevation right here, okay? The point where the ST segment begins, that point where it starts, is called the J point. Notice these J's are all over my board here. Look, how do we know the ST segment is elevated? Remember I said, remember the isoelectric, right? That's it. the isoelectric line's right here before the P wave. If I move it over, is that J point, is that ST segment up, down, or is it flat? Is it good? It's elevated. That is ST segment elevation. And if we have that ST segment elevation in a certain pattern called, give you a little preview, 2 up and 2 down. I'll explain in a moment when we get there. Hang with me. Then we can have a heart attack going on. And from the field, you as a paramedic or anyone out there that knows how to read an EKG can get your radio and say, open the cath lab, activate the cath lab, open the cath lab. We have a insert your wall of the heart STEMI heart attack. We're coming in. We're bypassing the emergency room because I can read this EKG and it's clear as day, a STEMI, a heart attack. I got 2 funky ones I just want to share with you before we get into some more of the meat and potatoes here. You may see what's called an abnormal Q wave. See our normal Q wave here, how it's nice and narrow and neat? Look at this wide, bizarre-looking Q wave. Sometimes we can have a wide Q wave if someone's had a previous heart attack. That's a wide Q wave. It's just wide, okay? Something to watch out for. What I always tell my students is, folks, if you ever see something funky on an EKG, you can always ask the patient and say, hey, has the doctor ever said you had a wide Q wave? Or an example of a bundle branch block. Hey, has the doctor ever said you had a bundle branch block? If they look at you like, I have no idea what you're talking about. That's, okay, well, that's not good, right? Maybe it's new, acute. If they go, oh, yeah, I remember. Right? Not that it's going to change your care because they're in your ambulance, but it's something to bring up. And any time I see something funky on EKG, even if the patient looks fine, I'm bringing it up to that nurse and I'm bringing it up to that doctor. And I'm circling it and saying, look, check it out. They look good, but they're showing you the EKG. Maybe you want to keep doing them. Right? My little other interesting one here is we lose the R wave. We lose the R wave. So we end up with this deep QS wave looking thing over here, and there's no R wave. So this, I just want to show you to the point of it. Why is it a deep QS wave? Because there's no R wave, and an R wave is a positive deflection. So instead of a QRS, we get a QS. So I just want to bring that up. If you see it, you can go, oh, that's a deep QS wave. Now back to our meat and potatoes. Let's go back up, folks, here. T wave inversion. T wave inversion. Look at my normal T wave. Look at, it's flipped, it's inverted, it's flipped over. If I see widespread T wave inversion on an EKG, and whether a patient is or is not, but they probably will be if they have this on their EKG. They have widespread T wave inversion. That is what we call a sign of ischemia. So we talk about infarction. Okay, so let's just say, for example, put my pen down for a sec. This is the coronary artery. If it's completely blocked, you're having a full myocardial infarction, which basically means heart muscle is dead and dying as we speak. Your red heart turned black. Okay. Let's say I have some plaque in there, or I have a vasospasm, like a Prinzmetal angina. You'll hear about that. Okay. Vasospastic, you might hear about that. So it's clamped down, or maybe I have some plaque in there, but there's a little bit of room left. With T wave inversion, ST depression, this is ischemia. If I see elevation, I'm thinking about infarction. This is why I say to all of you, and please hear me on this, if we see a patient with widespread T wave inversion or widespread ST depression, we don't see any elevation on the EKG, please keep printing, keep burning off EKGs, because the STEMI, the heart attack, it may develop right in front of your eyes, especially if you have a long transport. So remember this: inversion, depressions, all by themselves, ischemia. It's still an urgent patient. It's still a lighting sirens to the hospital. This patient's still going to be very sick. But this patient, we got to go right to the cath lab. But again, there are things out there, and we don't have time for that in this video, so stay tuned. to what we do here at Paramedic Coach. But if we see this 2 up, 2 down pattern I'm going to share with you right now, we have to go to the cath lab, which they're going to literally do a rotor-rooter, and they're going to, stent up the patient. Hope you're enjoying our lessons today. If you don't know, in the first link in the description is my Video Vault training. What you get there is access to over 480 videos and over 2,000 National Registry practice test questions. And we cover every level: EMR, EMT, Advanced EMT, Paramedic. This is where I send all my students, whether you're getting ready for school, you're in school right now, or you're getting ready for your National Registry exams. You'll see this video right here. Go watch that video and I will tell you all about it. Let's go back to the lesson. So let me show you right here, right now, what this is. So, introducing 2 up and 2 down. ST elevation is found in 2 or more contiguous leads or friends. I will explain, hang with me. Then, reciprocal changes are found in the leads opposite that area. An example, let's say we have ST elevation in lead 1 and AVL, which both look at the same view of the heart, the lateral wall. 1 and AVL are contiguous. They are friends, which means if I have elevation in 1 and AVL, and I have ST depression, remember the depression, in 2 and 3, or 2 and AVF, or all 3, or 3 in AVF, whatever combination you want, 2 or more friends. 2, 3 in AVF, they are friends, they are contiguous, they're looking at the inferior wall. If I have elevation, elevation, depression, depression, as an example, that is a lateral wall MI, a lateral wall heart attack. I can see from the EKG which wall of your heart is being affected, and most likely what coronary artery is being affected as well. And I'm going to show you that too. So hang with me. Now, this is the introduction of what it is. It's 2 up and 2 down. This is how we, in the field, diagnose, if you will, that the patient is having a heart attack, and we're going to literally call a bunch of doctors in the hospital and open up the cath lab. I want to go to the next slide because it goes a little deeper on this, and we're gonna explain a little more, so hang with me. Okay, here we go. These are all the leads, and I'm gonna go back just so we can see. Look here, 1, AVL, 2, 3, AVF. AVR has no friends. V1, V2, V3, and V4, V5, and V6. Let me go back to the normal EKG real quick, okay? Remember here's lead 1, here's AVL. They are friends. They are contiguous with each other. 2, 3 AVF, they are friends. Okay? AVR, that's for advanced discussion. We're going to hold off right now and say, AVR, you have no friends. No problem. V1, V2, look at the septal wall, the septum. V3, V4, the anterior, the front. V5, V6 is also lateral. Now in class you may hear of a type of heart attack called an extensive anterior MI, which is basically when V1, 2, 3, and 4, the whole front, is elevated. Not just the septum or the anterior, all of them are. And it's not uncommon to see all of them up, but we'll talk more about that. So now we have a picture of, okay, this is the actual EKG. Now I understand that when Evan says lead 1, and when Evan says the word lead, he means he's giving me a view of the heart. And now that I know lead 1 is a view of the lateral wall, if there's elevation in 1 and AVL, and that's 2 up, and I get 2 down, like in 2 and 3, which are opposite reciprocal to that, I'm going to open the cath lab because they're having a heart attack. So 1 is friends with AVL. 2, 3, AVF, they are friends. AVR, save it for an advanced discussion. Stand by. AVR, stand back, stand by. V1, V2, septal. V3, V4, anterior. V5, V6, lateral. So let me show you a little more here. We're going to keep going. So right here, we first started this call, I said, if you tell me what lead is affected, what lead is having myocardial damage, I can show you what artery is being affected. Here's a picture of the heart and exactly what that is. So if your inferior wall is the one that has a 2 up, okay, and the inferior wall is being affected, that's 2, 3, and AVF, those are the leads. I know your right coronary artery is under attack. Septal wall, that's going to be your, they call it the widowmaker because it's so common. The left anterior descending artery, the LAD. Also, if you look, the LAD affects all 3 of these MIs. So, that's what they call the widowmaker. Anterior wall is, again, the left anterior descending, the LAD, okay, V3, V4. And the lateral wall, well, the lateral wall is in 2 different places. The lateral wall is 1 in AVL, and the lateral wall is V5, V6, okay? Looking at high and low lateral wall. Now, with 1 AVL and V5, V6, yes, it's the LAD, but there's a branch of the LAD called the circumflex branch, and that's under attack in lateral wall MIs. Now, let's continue, and let's just do a little review of what we've gone over. I got a little extra, little bonus tip, a little pearl for you, so hang with me. 2, 3 AVF, we know that it affects the inferior wall. That's going to affect our right coronary artery. Lead 1, AVL, V5, V6, that's lateral. That's going to be the LAD, that's circumflex branch of the LAD. V1, V2, septal, that's the LAD. V3, V4, anterior, the LAD. Hey, whoa, Evan, what's this? Okay, give you a pearl. You're a paramedic in the ambulance. Your patient has chest pain, difficulty breathing, nausea, vomiting, and they've been so out of breath they can't even walk around. They call 911. You, as a good paramedic, you do an EKG. You go ahead, do an EKG. You find that 2, 3, and AVF, they're elevated. And you have reciprocal changes in one of these other leads. Talk about that in a moment. The inferior wall of the heart affects what? The right coronary artery, right? So if we see on EKG that we're having in our patient an inferior wall MI, we have elevations in 2, 3, or AVF, right? And they're contiguous. I recommend moving the leads over, which is going to be your chest lead. So what you're going to do is you're going to move, you can see here, 4, 5, 6. You're going to move all your chest leads over here. 3, you're going to move them over. Move over to the right side. What this gives you is it gives you a picture of, remember, the EKG is just a picture in a moment of time. If I move the chest leads over from the left to the right, now I'm getting a direct picture of what? The right ventricle. Think about your heart. Well, what's right here? And the leads are over here, are shooting right ventricle. So we're getting a picture of the right ventricle when we move the chest leads over to the right. Okay? And that is going to affect the right coronary artery. So we take the leads from the left side, we move them over to the right side. Same location, but move to the right, same intercostal spaces. And what we do is take a picture, take an EKG. If we see elevations, particularly in 4, 5, or 6, that's very concerning for what we call a right ventricular infarct, which means, quite literally, your right ventricle, the muscle of your right ventricle, is dying. That's what that means. And then, once we uncover that, we mark it. We mark it on our EKG, V4R, V5R, V6R, whatever. Then if you want to move the leads back over, that's fine. But that is when we're concerned about it, and I want to give you that pearl. Now we're moving on here, and now we're going to talk about where we might see those reciprocal changes on EKG. Breaking it down lead by lead. And I got another pearl for you at the end, another big tip you might not know about, so I'm going to share it with you. So, again, the infarction location, we talk about inferior. Inferior wall MI, where you have elevations in 2, 3 AVF. The reciprocal depression, what that means, 2 up is where the elevations are. The 2 down is the reciprocal depression we got to see to call it a clear-cut STEMI is 2 up and 2 down, okay? Now, you may see, which is totally fair, earlier on in a heart attack, you may not see the reciprocal depression. So if you're early on, you might only see elevations, which is, again, I'm going to say it again, keep burning EKGs because you're going to see it develop in front of your eyes. Now, with this, the reciprocal depression, some criteria may be, hey, look, to open the cath lab, you need 2 up, you need 2 down. But in some areas, all you need is, if you have signs and symptoms, chest pain, difficulty breathing, nausea, vomiting, back pain, dizziness, I feel like I'm going to pass out, unstable vitals, all that in a mix, risk factors, right? And you call the ambulance, and you're in the ambulance, and the paramedic sees, wow, those are 2 big elevations, but I don't see any depression. Most likely, you could still open the cath lab with seeing that, as long as not a clear-cut mimic, but that's for another day, folks, right? We're still in basics. That's more advanced. Hey, I hope you're enjoying the content here today. If you look down below in the links in the description, you'll find my EKG and 12-lead EKG masterclass. Paramedics, when they go through school, they have a rough time with cardiology and EKGs, but there's no reason to do that. If you're getting ready for school, you're in school right now, or maybe you're getting ready for national registry exams, this EKG and 12-lead EKG masterclass will get you to finally understand EKGs at the level you need to pass school, pass exams, and be confident out in the field. You can see the page right here. We hit the link in the description. Watch this video here. I'll tell you all about it. Now, back to the lesson. But, just want to make that clear. The reciprocal depression is not always there, and there's also heart attacks where, if you're having a heart attack, it doesn't show up on the EKG. That's called an NSTEMI. And again, we got a whole lot to talk about on this channel, so make sure to subscribe and stay tuned for, if you're loving this, man, stay tuned for more, and you can see all the links in the description as well. Inferior, 2, 3 AVF, we're going to see a 2 down and 1 AVL. Lateral, 1 AVL, V5, V6. Essentially, folks, everything is just the opposite of the inferior wall. Which, if you think about it, using your brain, kind of makes sense, because if the inferior wall is looking at, it's the inferior wall, it's looking at the right coronary artery, when we went through all of these other ones, like lateral and septal and anterior, right, they're all on the left side. So it kind of makes sense from a logistic perspective, like, well, they're opposite because they're on opposite sides of the heart. Pretty cool? I hope that's the way you can remember it, because that's how I remember it. It makes sense. So basically, everything is opposite the inferior wall besides itself, right? We can see here what is elevated and what is where we might see the depression. Now, a few characters here I want to bring up. Anterior septal, I call that myself the extensive anterior. That's when V1 and V4 is elevated. All 4 of them are elevated, okay? An anterior lateral, that, for example, would be like 1 AVL, and then you have, let's say, V3 through V6 up, as an example, okay? Now, here's my big pearl on this one. Have you ever heard, we're talking about the right ventricular infarct. We've all heard about that now, and now we know about it. What about posterior? So, posterior, we take 3 leads, we call it V7, 8, and 9. We move V4, V5, V6, we take it, we're going to bring it around the patient's back, and we're going to call it V7, V8, V9. With the posterior, what is going to, I showed you in the last slide, if a patient has inferior wall MI on your EKG, do a right side EKG. It's a tip-off that you might find a right ventricular infarct. What is the tip-off why I'm going to randomly do a posterior EKG and spend my time doing that on a critical patient? Why? Here's why. With the posterior MI, okay, that's obviously we have the anterior, the front, that means the back of the heart. What that means, you may see on a normal EKG that your They are your normal placement EKG with the left side of the chest, we talked about earlier. V1, V2, or V3 is depressed, and there's nothing else going on but that. That's what I mean by none. This is all looking at a normal placed 12 lead, okay? So you do an EKG. You see ST depression in V1 and V2, or V2 and V3, and nothing else. Your first thought, do a posterior. V7, 8, and 9, right across the back. Right here, we're going to go lead by lead, me and you, right here on YouTube, and we're going to go lead by lead with this EKG. We look here. What do? Is it up? Is it down? Or is it okay? Is it good? Is it up? Is it okay? That J point. Okay, here we go. Lead 1. Remember, hey, where is the isoelectric line? Before the P wave. Why do I keep saying that to you? Can I show you why? Here's why. When we look after the P wave, we're getting into the PR interval, and sometimes, in some conditions, there can be PR depression, like in pericarditis, for example, okay? So, the real true blue isoelectric line is before the P wave. So you have a T wave, after the T wave, before the next P wave, that is isoelectric, and always use that. You don't want to get fooled by using the PR interval, which is between the P and our QRS. Okay, so we look right here. Here's your isoelectric. Here's your J point. Up, down, or okay? What do you think? You tell me first. I'm telling you, it's up. Clear as day. Some people may call it the tombstone. Other people call it a fireman's helmet, right? That looks like, like capped, and you put a smiley face on it, right? However you want to remember it, the big front of the helmet, right? Then or a tombstone. Whatever you want to think of it as, it's elevated. Okay, and look how bizarre it looks too, right? So just looking at it, based on that, I just want to go back. So let's just go back. Here's a normal. Look at the difference. What a difference, huh? Now let's go to the heart attack. Whoa. Okay. Now, 2-3 AVF. Based on what we said, we should see depression here if it's really a heart attack, right? Well, let's find out. Up, down, or okay. I'm looking at lead 2. I'm really giving it a good look, and I would say it is, like a smudge down, if any, and possibly I would say it's okay. It's a smidge down, but it's not crazy. Not crazy down. It looks a little ominous. You can see it's down a little bit, a smidge, but not a lot. But enough in this case, especially with that. Okay, well, let's continue. Well, here it gets blatantly obvious. Is that up, down, or okay? Let's look. Here's our isoelectric. Move it across. There it is, J point. That's way down. Now, I don't need to look any farther. I look at AVL. I can see right here, look at that P wave. That's up. So, in most protocols, 2 up, you got symptoms, you're unstable, open the cath lab. Now, some might say, no, down the field, you got to get 2 up and 2 down. Well, okay, no problem. 2 up and very much 2 down. Look at AVF. There's isoelectric. There it is. Look how down that is. We got 2 up and 2 down. We got a lateral STEMI. Now, just for fun, let's look at the other leads just for fun, just to practice. AVR, we'll save you for the master class in the description. Okay, AVR, we'll save you for that. V1's a little down, folks. V1's a little down. V2 is a little down as well. V3 is down a little bit as well. V4, those T waves are pretty pointy, and I'd say it's right on the cusp, of being elevated, but that T wave is mighty pointy. So what I want to share with you is this. And we didn't talk about this earlier. This is a point to mention. If we see something called hyperacute T waves, the way I think about it is this. Essentially, a T wave that is literally almost as tall as a QRS. Look at that. Now again, let's go back to normal again. Let's go back to normal. Look at the T wave in V4 and V5. Just remember this in your brain. And there are other things. People in the comments.
And hyperkalemia has tall T waves.
Yes, I'm aware of that. Yes, we're doing a basic lesson, folks. Look at the difference. Look at the difference in T wave. Pretty crazy? Pretty cool? You see the T waves here are still, in these leads, they're a little bigger. But if we go back and look at the heart attack, look at the T waves. I mean, they're massive. Something to look at. Something to think about. If you're ever on the fence, okay? V5 is definitely elevated and V6 is elevated. I mean, folks, this is lateral STEMI all day. V5, V6, 1 AVL are all up. And we got 2 down. Well, maybe, again, 2's down, but just a smudge. But it's, I mean, no doctors are arguing with you that AVF and 3, they're down. So that's a heart attack. Now let me give you another one. Lead 1, up, down, or okay. Well, I'm looking at it, and I'm saying that lead 1 is actually a little bit up. So we'll watch out for that. Okay, we'll watch out for that. Lead 2 looks okay. Lead 3, smidge down. AVR, we'll save you for the master class, link in the description. AVL, that's up. So we got 2 up right here already. And AVF, we can see here is down. So we're almost repeating last time, but look at the big difference. Now, I mentioned the word tombstone elevations. This is a classic tombstone elevation. It looks like a tombstone, right? This is your classic tombstone pattern. I want you to remember this pattern for the rest of your career. This is exactly what a heart attack looks like. So we can see here, look at this pattern. Up, 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 and we see V6, up. Okay? So what do we have here, folks? Well, we have an extensive MI. We have a clear-cut anterior wall STEMI. And it looks like we even got some lateral involvement. So this is an anterior lateral STEMI, and we got reciprocal changes here, again, in 3 and AVF. Are we going to open the cath lab? Yes, you are. Now, the last thing I want to leave you with is the definition of this. STEMI versus NSTEMI. Now, I'll leave you with this. If you enjoyed this video so far, give me some love. Make sure to like this video, hit subscribe, and check out the links in the description for all my education courses and tools, study tools. You will love them. I'll leave you with this. I want to talk briefly about STEMI versus NSTEMI so we understand it. We're going to do other videos in this channel about more cardiology. Let me know in the comments what you might want to see. It's going to be awesome. We're going to do a ton of content here, and we made a lot of awesome presentations for you. So STEMI is an ST elevation MI. The ST segment rises greater than 1 small box on the EKG above the isoelectric line. The ST elevation must be present in 2 or more contiguous leads. That's enough to open the cath lab, again, or per your protocol, which is why I say that, because in some areas they might say, we want to see 2 up and 2 down, and we're not opening the cath lab for EMS. Or they might say, if you see 2 up, fine, open the cath lab, which is good to do. Just different protocols, different doctors, different medical directors, different hospitals, different areas, just letting you know about it. There's nothing wrong, there's nothing right, it's just what it is. Now, what is it? What's an NSTEMI? Well, it's a non-ST elevation MI. The EKG shows no diagnostic signs of ST elevation. What this means, let me share with you. You go to a patient, they have chest pain, difficulty breathing, nausea, vomiting, back pain. Again, I'm so weak, can't get out of bed. You do an EKG, it looks fine. But their vitals don't look fine. But the EKG, you get another one en route while you're getting your IVs. The EKG is still fine. Maybe you give them aspirin, you give them nitro, give them some pain medicines. You're helping out their oxygen levels. You're checking their SpO2. Maybe you throw them on capnography. You're listening to lung sounds. The patient's unstable, but the EKG is fine. Get to the hospital, they draw blood work. They draw blood work at hospital, and their cardiac markers, their troponin levels are elevated. Their cardiac markers they drew from the blood work show they're actually having a heart attack. And the patient goes up to the cath lab. Now, I'm going to give you a little preview. So again, folks, I leave you with this. We find a patient on EKG having a heart attack at the STEMI. In STEMI, the blood work finds it in hospital. You know what's right in between that? Well, there's a new diagnostic criteria, if you will, called OMI and NOMI. And I need your help on this one. If you're someone who watches me here, I want you to go look in your local protocol. Do you have a OMI or NOMI criteria where you're working? If you're a student, just Google your protocols. I'm just so curious. Do you have a OMI or NOMI protocol in your area? And what that OMI and NOMI protocol, what that is, I'll show you what it is it is going to help find patients who, well, the EKG looks okay, but we see something on the EKG or something in them, we can still open the cath lab, versus this NSTEMI patient sitting in the ED waiting for blood work and they're having an active heart attack. So I'm very curious to my fans that are out there. What's your OMI or NOMI protocol in your area? Because that protocol can be widely different in a particular area. So let me know what it is in your area. I'm so curious. Drop in the comments. I'd love to get a discussion on that in the comments. And if you know anyone who's getting started with medic school or getting ready for medic school, share this video with them so they get the basics down. The number one way to get ahead of school and class is to get an awareness level. That's why we're here at the Paramedic Coach. And I'll see you in the next one. By clicking in the first link in the description, you get lifetime access to my Video Vault program. The Video Vault includes over 480 videos of content and now holds over 2,000 National Registry practice test questions. Also includes some really awesome bonuses like worksheets, drug cards that are pre-filled out all for you, community group access to ask me questions, and audio files when you are on the go. The Video Vault will find you no matter where you're at, whether you're an EMR, EMT, advanced EMT, or paramedic student. And my students use this whether you are getting ready for school, in school right now, or getting ready to go pass your National Registry exams. So click the first link in the description right now and get yourself lifetime access to the Video Vault today. I'll see you there.